Hello, everyone. I have a very special guest today, Dr. Jacqueline Michael. She's joined all the way from Australia. Thanks a lot, Doctor, for joining in for our audience.
Thank you, Rajiv. Thank you for having me.
Thank you for agreeing to this at such a short notice. I'll give a short introduction of Dr. Jacqueline. She's a Malayali. She completed her MBBS from the TD College, Alapura, and then did her post-graduation in infection and immunity from the University of Sydney. She is a lifestyle medicine expert. She's a international board certified physician of lifestyle medicine. And she believes in something called, she's a proponent of therapeutic lifestyle change. And she has been working with clients, helping them lead a healthy lifestyle for more than a decade. So welcome, doctor, and thank you once again for joining in. My first question is that you did your post-graduation in infection and immunity. What a better time to talk about it than times like these today. Though our topic is about diabetes, the unseen pandemic, we often also hear a lot from newspapers that people who succumb to these kind of diseases and more prone are people with these kind of lifestyle disorders. And I think you are the right person to talk about it because you can very well link up both. What is your take on it?
Okay. So what we can see from a lot of studies that are happening in parallel during this epidemic itself is that what is coming out is that a lot of people who are obese and overweight seem to be having it tougher when they get the infection and also perhaps succumbing to it more. We also find that many people with vitamin D deficiencies and people like us with a darker skin tone, for example, in the United Kingdom, they found the disparity between those dying from COVID from Black and other ethnic minority groups to be far higher than the native white Caucasian race. So there are a lot of studies. Some of them could be socioeconomic, but there seems to be some kind of link between vitamin D and obesity and different lifestyle diseases like that. So obviously there is a link. So let's wait. It's like, what's the spot? We're looking for the evidence to come in to actually pinpoint what the things are.
Right. So you also mentioned that you're a lifestyle medicine expert. Could you explain what exactly is lifestyle medicine to our viewers?
Okay, thank you. It's a very relevant question because see, lifestyle medicine has often been the monopoly of, only alternative therapists or naturopaths or things like that. But see, if you look at Hippocrates, right from the beginning ages of modern medicine, what we call Hippocratic medicine, he said, let food be thy medicine, right? And medicine be thy food. So this is a very ancient specialty that's coming into its own in today's day and age, say for the last 10 to 15, 20 years. It started as a movement in America and now is all over the globe. And there is a dearth of there's actually a big vacuum in the field of good evidence-based lifestyle advice, because the commonest advice you would hear doctors perhaps giving is that, you should eat healthy and you should exercise more. But there's a lot more to it. We need to go a bit more in depth depending on the condition of the person and be equipped to give that advice as a physician. So yes, we are trying to fill that space and increase capacity. I'm also the joint secretary of the Indian Society of Lifestyle Medicine. So our aim and hope is that we build up that capacity of trained lifestyle medicine physicians, as well as nutritionists, exercise physiologists, a workforce who is able to deal with the pandemic right in front of us, not the coronavirus pandemic, but the pandemic of lifestyle diseases.
Right. So when I came to you with a series of topics that I wanted to discuss with you and gave talking as to which one would be relevant, you didn't have to think twice before deciding on the topic diabetes and unseen pandemic. Why is it such a villain? Is there some statistics, some information that you can throw? Do people take it lightly? Where is the real issue?
Okay. Good question. The real issue is that diabetes among Indians and among the Indian diaspora it's now so common, and especially in Kerala, people take it very, very lightly. I'll just give you a little bit of statistics for you to understand how far we have moved. There's been this long-standing study that happened from 1990s till 2016. So actually, the prevalence of diabetes rose 64.3% from 1990 till 2016. And ischemic heart disease, which is closely linked to diabetes, 53%. Cerebrovascular diseases, which has our strokes and things like that, went up 53.9%. So that is where we stand now. And if you look across India, you would find that South Indians especially do have far higher rates of diabetes as compared to North Indian people. Yeah. Yeah, so it's pretty bad, and it's pretty bad among the diaspora as well. So you also working in the lifestyle realm, if there's something that we can do for society that will definitely make an impact, it's with diabetes.
Maybe I think because people think that my blood sugar levels are high, it's not really preventing me to do. I don't have a pain per se. Maybe I feel slightly lethargic or things like that. It's not really affecting my quality of life, is what people generally think, without actually realizing the repercussions of it, right? So could you throw some light in terms of what are the repercussions of diabetes, which is not attended to for a longer duration? How does it affect other organs or other functioning of the human body?
Yeah, just while coming to that, I also have to make a mention here that we, as in India, have the second highest population of people with diabetes. Okay, and of this, actually, around 47% of our diabetic haven't been diagnosed. They are undiagnosed diabetes. Okay, and we have a prevalence of around 10% as pre-diabetes as well. Okay, so there is this phase. If you look at, take a time graph, there is this phase where we are entirely normal. Then there is this phase that we go into pre-diabetes, and by the time our blood sugars are raised enough and we go to the doctor and get a diagnosis of diabetes, we are well on that journey of having the different parts of our body to actually being affected by these raised sugars. Okay, so and then we get put on medicines, and for some, actually it's only between 10 to 15% of the population who do have the sugars properly controlled. Okay, but from the time because that's the only date that we have from the time of diagnosis. Actually, your clock is ticking, and there are studies to show that between 9.9 plus or minus 5 years, you can actually start to see complications from diabetes. And it starts with your nerves. It could be you might get tingling sensations in your nerves. You could have erectile dysfunction. It could affect your blood vessels. It could affect your heart. It could affect a whole host of your kidneys, your eyes. In fact, there are hardly any organs that diabetes does not affect. But the problem is, even the complications are diagnosed far too late if you're not in proper schedule of having everything checked and monitored regularly and things like that. So just when you've got your diagnosis of diabetes, it's already too late. We need to move from diagnosing diabetes to diagnosing pre-diabetes if we have to make an impact, Rajiv.
I was reading an article, doctor, that you were mentioning that it is far, far higher in Kerala. I remember reading an article that among the Malayali population, the prevalence is more than 20% higher than the national average. And this happens in our Kochu Keralam, which is supposedly literate. 100% സാക്ഷരത കൈവരിച്ച നമ്മുടെ കൊച്ചു മലയാളി കേരളത്തിനകത്താണ് the prevalence is so high, which is frightening.
നമ്മുടെ കൊച്ചു കേരളം leads India in diabetes. And Kochi has around, among all the metros, okay, Kochi has a diabetic prevalence, the latest I read, about 20%. Chennai is quite close with 13.5. And as you go to the north, it's a bit better. But this is the story in Kerala. So that means every 1 in 5 adult has diabetes. And that is why people are not taking it seriously.
Yeah. So common. I have it, you have it, so what's the big deal?
Yeah, ഒരു വിത്തൗട്ട് ചായയും ഒരു മോർണിംഗ് വാക്കും ഉണ്ടെങ്കിൽ ഞാൻ എന്റെ ഡയബറ്റീസിനും ലൈഫ് സ്റ്റൈൽ മാനേജ്മെന്റ് ആയി എന്ന് ചിന്തിക്കുന്നവരാണ് നമ്മൾ പറയുന്നത്. പിന്നെ ചോറ് മാറ്റി ഗോതമ്പും കൂടെ ചപ്പാത്തിയും കൂടെ ആക്കിയാൽ എവറിബഡി ഈസ് ഹാപ്പി.
Right. See, Panda, yesteryears, in the 10-15 years, it was such a fashion, it was such an in thing to say, Adhyana diabetes ato without sugar madi, right? Take it without was such a fashionable statement to say, because it was only prevalent among the rich or the upper class. And that's not the case anymore, right? It's funny when you think about it on those terms.
Good point, because now we are seeing that the rural population is also catching up. And it's most frightening, because the rural population, they don't have to be obese. You're finding a lot of obese, diabetic patients among those who are not obese in the rural population.
Right. So you're saying that you don't have to be necessarily obese or overweight to be diabetic.
Not at all. Not at all.
Right. So when we talk about diabetes, there are different types, right? Type 1, type 2. Are both reversible? Can we call it reverse, or would you call it manageable? What is the difference between type 1 and type 2?
Okay. Very quickly, type 1 is usually commonly seen in childhood. It's attributed to an autoimmune condition where your pancreatic beta cells get destroyed, and as a result, you can't produce enough insulin, so the children have to be put on insulin. Okay, so I have read a few case studies, a handful of case studies where it has been reversed, but that is more as a function of correcting or managing the autoimmunity there.
Okay.
And then as a consequence,
so when you say children, what age does it typically happen? Is there an age?
Type 1 diabetes can appear quite early in life. It's only the period when you die. It could take a while to diagnose, because in children it could appear quite early in life. On the other hand, type 2 diabetes, we are very cautious when we say, can it be cured? Okay. But in my experience, I've seen that it can be reversed to a great extent. Okay. Depending on how far the damage to your pancreas and liver has happened, it can be reversed to a great extent. And in some people, of course, completely reversed. But in a great proportion, I think, in fact, in most people, it could be reversed to a certain extent. At least get them lower their medications, lower their insulin, and live a far more healthier life. That is something we can do through lifestyle changes, therapeutic lifestyle changes. Yes.
Right. So how does a person know, without actually checking? It's actually two questions clubbed as one. How does a person know that the person is having high blood pressure, or the blood sugar, or the blood sugar levels are not being managed, without checking the blood work? Is there any physical, symptoms or something that a person would feel which would make them curious or suspicious that their person is having diabetes? Question number 2, once they want to confirm that, what kind of test do they do? And because we hear about fasting blood sugar, the glycated hemoglobin, HbA1c, what is the difference between these two? Which is more reliable?
Okay, let me go to your first question. See, it's called like polyuria and polydipsia. Basically, you feel very thirsty and you drink a lot of water, keep drinking a lot of water, and you also feel like peeing a lot more, going to the washroom quite often. So those are the very common symptoms you may have. You might also lose a lot of weight as a result of diabetes setting in, but by that time, it's already too late. In fact, I just told you the stats that almost one in 5 adults in Kerala could be having diabetes. So the level of undiagnosed diabetes is even far higher, and pre-diabetes is even far higher. So it is worthwhile. Let's go to the investigation that you just spoke to me about. It is worthwhile, in fact, for people in their late teens or even the early 20s to go and start having their blood works done. And definitely, if you're in a very sedentary job like the IT sector or something like that, you're in your 20s, make sure it is done. And here I have to differentiate. Most people just go and do the fasting blood sugars. Okay. And when you do your fasting blood sugars, what happens normally? Say, I am going to do my fasting blood sugars tomorrow. How will I be eating today? Rajiv, how would you eat if you were going to have your fasting blood sugars taken tomorrow?
Well, I'll tell you what my clients do. They know that tomorrow I'm going to take my fasting blood sugar. So they will eat less because there is this subconscious guilt which is playing in their head. They'll eat less. They'll eat much earlier. They will have a good sleep. They'll go to bed earlier. So which is not their actual lifestyle. And that's what they do. And then next day they see. So I keep telling people, if it is a planned blood sugar checkup, your actual blood sugar checkup in the previous days would be much higher. What is your take on it?
Yeah, absolutely, and that's the same for cholesterol as well. I know relatives of mine who say, no, Jacqueline, we're not going to do the test now. We'll do it after 1 week. Let me just clear up my act. Right. Let me clear up my act. So they are aware. See, it's not a lack of knowledge. They are aware that their lifestyle is going to contribute to this. So I do not consider the fasting blood sugar to be a reliable indicator of your pancreatic function or your liver's function, or whether you're a diabetic or not, precisely because number one, people change their habits just before taking the fasting sugar. Number two, your insulin sensitivity should have been that much impaired for your fasting blood sugar to really show up. Okay, so let's look at it from a point of a person who is a diabetic. Of course, he needs to do HbA1c, and I'm sure that is happening right now. People do check both, so that gives you a far more reliable indicator of how well the disease is being managed. That's from a management point of view. Now, if you are on the lookout for pre-diabetes, in my opinion, fasting blood sugar is not a good method to check that. You really need to be doing your your HbA1cs, and looking at that. If you have a HbA1c between 5.7 and 6.4, then you are pre-diabetic. For me, I would like to see everyone's HbA1c below 5.5. So anyone above 5.5 or above, I say, we have got to start to work at it right now. Don't wait for it to go more than that. And 6.5 or above 6.5 is purely diabetic, regardless of the fasting blood sugar or 2-hour postprandial or insulin glucose, IGTT, whatever it is.
Without getting too technical for our audience to understand, could you tell us why HbA1c is the reliable factor?
Okay. Very quickly, HbA1c simply reflects your blood sugar levels over the previous 3 months rather than giving you a snapshot. It's like a time-lapse movie. Okay, you have a photograph, it gets you an instant. That's the fasting blood sugar. Your HbA1c is a time-lapse movie. It gives you the snapshot of the last 3 months, and that is also from nowadays. The American Diabetic Association has a new calculation. You can do something called the estimated glucose average, I think so. Let me just it's EGA, and yes, it's the estimated average glucose. Okay, EAG. There's a calculation that you can do based on your HbA1c levels. And that gives you a fairly good indicator of how your sugar levels were, past.
Right. So if a person is pre-diabetic and wants to further understand what level he or she is in and what needs to be done, does that person have to do a glucose tolerance test or things like? Is it really required, or what is your immediate course correction advice to such a person?
So if he's pre-diabetic, I think he really needs to course correct via a therapeutic lifestyle change program.
Right. So what is the role of the medicine there? And I also wanted if you could touch upon, should a person rely? Because, I have clients who come to me saying that, I was diabetic, but now all diabetic is all fine. Now my blood sugar levels are controlled. So I asked, how is it controlled? Oh, I'm having glycomate 500. Right. So they don't understand the difference between controlled and managing. Right. So if you could also touch base upon that in your, I think they would love to hear from the horse's mouth.
Okay. So the most important thing is, let me go and talk. Let me talk to you a little bit about arsenic. See, I'll tell you. I'll get there. See, when we take arsenic normally in our food. Okay, a little bit of arsenic comes into our body when we consume rice and a lot of different other products in tiny quantities. But our liver and our body is able to manage that small amount of arsenic. Right. So it is not a toxin for us. So it's not a toxin. So when you consume anything in excess to which the body can manage, it becomes a toxin.
Right.
Okay, so this is the same principle that affects diabetes. Okay, when I'm talking about type 2 diabetes. Okay, so when you consume something, okay, any substrate that can be converted into glucose in excess to which the body can normally deal with, it becomes toxic to the body. Okay.
Right.
And for this, there are various ways we manage it as a physician, as a doctor. You can give medications to improve insulin resistance, to push more of the glucose into the cells. You can give medicines to bring down the sugars. We play with a lot of pharmaceutical agents. Okay. But what is the cause? As a lifestyle medicine physician, when someone comes to me for a program or coaching, my issue is I really want to see what is going on in his life that is causing this to reach this toxic level, that he's got a disease right now. So we go and correct the cause. Now, it could be sleeplessness. It could be a sedentary lifestyle. It could be the amount of food, the amount and the quality of food that he's consuming. So we really have to narrow it down for the patient and address those causes.
Right.
Have I answered your question?
Yes, you have. I want to touch base on the importance of the exercises. So typically, what I've seen people do is that when they're diabetic, they cut down rice. Okay, is that the solution to diabetes?
The problem there is they cut down rice and they bring in ragi, they bring in wheat, they bring in some other cereal. Okay, that is my issue. I have an issue with that because they're all starchy things. Okay, you're removing one. Yes, there is an issue to talk about. There is this thing about glycemic load and glycemic index. Of course, there are certain cereals with a higher glycemic index and lower. So you can choose the lower glycemic load one and have that. Okay, but the key issue there is it's not good enough if you're just saying that rice is the bad guy. Rice necessarily isn't the bad guy. It's also a lack of the fiber that you're taking, the state of inflammation that your body is in. Okay. Now, coming to the point of exercise, it's good to do exercise, but most often we see people with diabetes just going for a morning walk. Going for a morning walk is good. In fact, we all should do that. We should get 30 minutes of exercise at least 5 days a week, moderate intensity exercise. But a diabetic needs to have some special exercise. Don't you think so, Rajiv?
Absolutely.
I'm sure you have
absolutely.
Yes.
So I keep telling people that walking is not even an exercise. It's a light cardiovascular activity. People go walking for half an hour, burn 150 calories, comes back and eats 2 extra dosa, which is 200 calories gone. It's a point lost. So absolutely in agreement with you. So is there any particular kind of exercises that you would suggest, or would that depend upon age and physical ability?
Of course. No. Regardless of age, because the age and their physical ability, the only thing you need to moderate or vary is the intensity or the repetitions of the exercise.
Absolutely.
But regardless of age and ability, if you are a diabetic, you need to do exercises that work your muscles. You need your muscles moving. You need muscle strengthening exercises, and you know more about that.
Right.
So those exercises need to be built up. You actually have to do resistance training. There are no two ways about it. Resistance training in small doses actually improves insulin resistance. See, there are two parts to this. There is increased blood sugar. Is absolutely insulin sensitivity, because there's increased glucose in the blood, and you have the insulin knocking on the muscle cells, and they're not sensitive. But once you start exercising those muscles, the insulin sensitivity improves and the sugar can go inside.
Absolutely. Cool. So I have a request to you, Doctor. Would you please take a webinar on diabetes a little more in detail? We'll keep it as a paid webinar. We'll get people to register for it and then do that. Sometime during July, we'll decide on the timelines and date and everything later. Would you be okay in doing that on our getting more into what needs to be done, more details into lifestyle modifications which needs to be done, etc.? Would you be able to do
I
that?
think that sounds, yeah, it sounds like a very good idea. And Rajiv, if we are organizing something like that, I think it should be open to the diaspora.
Yeah.
Because the Indian diaspora, see, my main main reason that drew me into lifestyle medicine as a specialty, in fact, was the fact that the Indian diaspora are so many times in excess of the native populations wherever they live in getting cardiovascular diseases and in diabetes.
Yeah.
You see, so this is a very, very, very important thing, and if we are doing that, I think we should open it up to people living all across the globe, as well as India.
Brilliant. So it's a great idea. I think let's go ahead and do that. I'll probably touch base with you after this interview, and we'll concur on a time, details, and everything, and we'll take that forward. Yeah. So if I know that you work with people, help them manage lifestyle diseases such as diabetes and various other, not just about weight loss, but also about many other lifestyle disorders. If one needs to reach out to you, where can they find you? I know you do a lot of very interesting YouTube discussions and everything, but could you give more details about that to our audience so that they also can go in and check and can reach out to you? And how can they reach out to you? Any email ID or any details?
I have a very public Facebook profile. It's just Dr. Jacqueline Michael, and you can send me a message on there. I am open to messages if it's a genuine inquiry. Yeah. I also have a website. I'm not very good with IT and tech, so it's a very simple, basic website, drjacquelinemichael.com. It's you can use the contact form over there to get in touch with me. So those are the ways that you can get in touch.
Cool. Yes. Thanks a lot. I'm so thank you and grateful for your time. 30 minutes. I think we have come to an end of this discussion. I'll definitely touch base with you to discuss more on this webinar, and let's plan that, and let's do it in a proper grand manner, and then actually get into the details of what one should be doing to manage these diseases. Yeah.
So I want to thank you, Rajiv, because of your enthusiasm and your passion for lifestyle, all that you're doing there in Kerala, and the new venture, Nuvo Vivo, an amazing site, and all the things that you do through that. Thank you for that. And with regard to the webinar, it will be value packed, and it will be jam full of value. I will take the core concepts from my 8-week program, condense it, and make it into a shorter webinar for your clients. We could do that.
Sure,
Yes.
sure. All right. So thanks a lot. Thank you once again. And bye, everyone. See ya.